So first, let's talk about the treatment of nociceptive pain. Remember, nociceptive versus neuropathic. They are two different types of pain. Neuropathic primarily involves the nerves and has some kind of a lesion associated with the nerves. So usually that's the stinging, burning, kind of your foot's asleep type of pain. Versus nociceptive pain is kind of the pain that we're most used to talking about. You've broken something, you have a bruise, things like that. So we're going to start out with nociceptive pain. Now, nociceptive pain can be divided into two different groups, as I mentioned before. You have somatic and you have visceral. But overall, the treatments for both are somewhat similar. Anywhere where there's a notable difference, I'll let you know. Goals of therapy. First thing is you want to remove or cure the underlying disease. Now, this could only be true for acute pain, and it's mostly if possible. Decrease your pain to a tolerable level to improve quality of life and maintain function and facilitate recovery. It is almost impossible to make somebody's pain zero. Our goals are to make it to a tolerable level. We want to minimize adverse effects. Many of these drugs can cause various adverse effects, including opioids that we may want to try to avoid overprescribing. And then acute pain, one big thing that we're trying to prevent is that turnover to chronic pain. Now, there are various acute pain and chronic pain guidelines. I just put these here so that you guys knew where I'm getting this information from. It's not just because Dr. Jordan likes to treat pain this way. As we're approaching our treatment to nociceptive pain, the first thing you have to do is make sure that it is nociceptive pain and really define whether it is nociceptive or neuropathic. If your patient is complaining of electric shock, numbness, tingling, anything like that, move over to the neuropathic pain section. If the patient has something broken, it does seem more nociceptive, this is where we're starting. Now, if you can find a source, try to treat it. Now, for acute pain, that's based off source and insult. Your ankle hurts, etc., etc. You have a broken ankle, we splint it, all those things. Chronic pain can be a little bit more difficult because sometimes there may not be an underlying condition we can find. And additionally, there are times that it could be related to like pain created by like chronic disease states. Like, for example, Crohn's disease. That is visceral pain. It does occur in the bowels. And trying to treat the Crohn's disease will help their overall pain. Other things associated with pain could be including things like sickle cell disease, which uses a lot of opioid related therapy. And then also you can think about like more structural causes for chronic pain. This could be things like bulging disc, degenerative joint disease, sometimes osteoarthritis, things like that. So let's start out with our approach to acute pain. Of course, our first step is always to collect the patient information and try to control the underlying process. This could include things like splinting, immobilization, things like that. Similarly, as we go to step 1, we really want to focus on non-pharmacological therapy. As we have more pain, or if the patient's pain is at that moderate level, you can start adding non-opioid pharmacotherapy. And we'll talk about some of those non-opioid pharmacotherapies just momentarily. Step 3 really involves opioid therapy. Now you'll see here that if patients have trauma or an invasive surgery, you might need to start at step 3. So for example, I have a patient that comes in with a motor vehicle crash. I'm not going to start out by just saying like, how about we try some breathing treatments and Tylenol and Toradol or Tylenol and ibuprofen. I am probably going to start out with opioid therapy. So it is okay that if you need to start here, you can start here, especially if somebody has trauma or has a major surgery or has just major pain. As opposed to if you're treating outpatient, you most likely can start at step 1 or step 2. Let's look at the chronic pain. And you are going to see things very similar. Our first step is first collecting the pain management, but then also optimizing non-pharmacological therapy. As we move on, we will try to use non-opioid therapies, very similar to the acute pain, primarily NSAIDs. The reason NSAIDs are considered second-line therapy is because they do have a little bit better efficacy than Tylenol. And we'll kind of talk about that as we go through. Then you can move over to your second-line therapies. Then we can move to our second-line therapies. Now, if somebody has a contraindication to a PO NSAID, then we can also consider second-line therapy. But that can either be Tylenol or a topical agent. We'll come back and look at this again once we have our pharmacotherapy toolbox filled. And then we have our third-line therapy. These are those adjunctive agents such as SSRIs, SNRIs, and seizure medications. Then opioids. So what you should see here is that we try to maximize non-opioid therapy first and then start opioid therapy. And this can include adjunctive therapy that we'll try to start first. Please note that if you do give an opioid, try to have it at less than 50 morphine milliequivalents per day. And if it does get to greater than 90 morphine milliequivalents a day, you probably need to evaluate the risk versus benefits. Additionally, if they're over 90 days on opioids, you also should evaluate the risk versus benefit. And then finally, there are special guidelines for lower back pain. What you'll see here is that you do want to start out, once again, with non-pharmacological treatment. If pharmacological treatment is desired, you are going to see skeletal muscle relaxants used earlier. Second line, this is an SNRI, duloxetine, or tramadol, and then third line opioid therapy. Similar in some ways to what we saw in chronic pain, use of duloxetine earlier is notable, and then also the use of skeletal muscle relaxers earlier, and that is specifically for lower back pain. So let's go a little bit deeper into our approach to acute pain. So let's start out with step 1, non-pharmacological therapy. Non-pharmacological therapy for pain, and this could also be true for chronic pain as well, can include multiple different things, including local care such as ice, heat, rest, and elevation. You can also see splinting is listed here, and TENS. Now, TENS is these electroshock compulsive therapies that like mostly physical therapists do. What they do is it provides like shock to the area, and it can be very helpful as far as pain management. As we look at comprehensive and integrative therapies, you see things like acupuncture, massage, and chiropractic therapy. Some patients do find relief with those. Rehab therapy, including physical and occupational therapy, exercising. You'll notice that most of these exercises are exercises that are considered low impact exercises. And then also, if the patients do have psychosocial factors, especially as they get into that chronic pain stage, you might consider things like cognitive behavioral therapy and other types of therapy. Another big part of pharmacological therapy or non-pharmacological therapy is patient education. So we do want to make sure that one, you set the patient up with appropriate expectations. As I mentioned before, most patients, we cannot get their pain to zero. Keeping that in mind, you do want to make sure that we talk about what the tolerable level for said patient is. I always ask my students every year during rotations, what is our goal pain level? And whenever a patient says 0 or a student says 0, I get upset. The goal pain level should be whatever is tolerable to the patient. Some patients can live their life at a 6. Some patients can live their life at a 3. You do have to have those conversations. You do want to make sure that you treat the sleep disturbances as well. If you are going to use pharmacotherapy for sleep disturbances, try to use non-benzo or non-benzo-like pharmacotherapies such as melatonin. And then also trying to create things like pain neuroscience education, especially for chronic pain. Now, these are listed 1, 2, 3. It's mostly just for slide reasons. You don't have to use all 3 of these in this order. You could start out with one over the other. I will say sleep disturbances and pain neuroscience education really do rely more on the chronic pain. The pain education would be a chronic and acute. Now we talked about pharmacotherapy. Let's talk about non-opioid pharmacotherapy. There are a lot. Now, I will say we do consider NSAIDs and Tylenol non-opioid analgesics, versus these are more considered like adjunctive therapies. And depending on the adjunctive therapy, you may use them in different ways. NSAIDs have been shown to be a little bit more effective in pain management. They also have those anti-inflammatory properties along with anti-analgesic properties. So that's another reason why they may be used first line. However, some patients may not tolerate an NSAID, and it can be a good alternative therapy. Then you have symptom-driven adjunctive therapy, as I mentioned before. This can include things like gabapentin and pregabalin and some anti-epileptics. These are primarily used for neuropathic pain. However, some patients do find benefit in these agents in nociceptive pain. Skeletal muscle relaxants, as mentioned before, can be used especially in lower back pain or as a third line in chronic pain. Serotonin norepinephrine reuptake inhibitors, primarily what you can think of here is duloxetine, and that's what you saw in the lower back pain. It does have a higher indication in lower back pain or chronic pain as opposed to acute pain. Let me go to tricyclic antidepressants. Again, neuropathic or chronic pain is typically where you see these. Local analgesics and anesthetics, capsaicin or lidocaine, typically are used for chronic pain. They also have a place in neuropathic pain. And then ketamine. Ketamine is used primarily for acute pain in patients that have severe acute pain, such as in traumas. We will talk about all these drugs later and give you like the patient or the specific characteristics. I just wanted to give you guys like a stage setting here. So if you didn't get everything I said just now, it's okay, we will come back. When we look also at step 2, we talk about non-pharmacological approaches and non-opioid pharmacotherapy. We do want to talk about non-opioid pharmacotherapy. It should be considered in all types of acute pain where non-pharmacological treatments are not effective or would not be considered for monotherapy. So if a patient does have pain, you don't think that it's going to appropriately be treated by opioid or by non-pharmacological approaches, it's okay to go ahead and start here with this step 2. Now, you can use topicals or orals. Really, the thing that is going to determine whether or not you want to have oral therapy is number 1, if the patient doesn't respond to topical therapy, or number 2, that they have systemic or widespread pain. As opposed to if they have pain in just a singular joint, topical therapy, or even 2 or 3 joints where it isn't everywhere, topical may be appropriate. I gave you an idea. So topical NSAIDs, that's primary diflucan. Not diflucan, I apologize. Diclofenac. That you will see as a topical NSAID. Lidocaine and capsaicin are also agents that can be used. They are not NSAIDs, obviously. And then finally, we have non-pharmacological approaches in the step 3, where we also can add on opioid pharmacotherapy. And you'll see here that the goal here is to only have about 3 to 5 days. Once again, you can start here if you do have trauma. So you do want to limit this to 3 to 5 days in the treatment of severe acute pain, or if the patient hasn't responded to other interventions. You can extend to 7 days, especially in select cases. This does differ from the law. So in law, or like whenever we talk about the laws, they are going to mention things like 7 and 14 days. That is the law, as opposed to this would be like the best approach to patient care. The law can be a little bit less restrictive, as opposed to patient care. We do try to keep it down to that 3 to 5 days. Now let's move to chronic pain. We've already gone through this. Just want to remind you, we've talked about a lot of these agents as well. I just wanted to have you guys note where some of the agents that we've talked about so far fall. So like skeletal muscle relaxers and SSNRIs. Opioids are considered third-line agents. Tylenol and topical agents are considered more second line. PO NSAIDs are after non-pharmacological therapy, etc., etc. And once again, you can see these lower back pain considerations. I just wanted to bring back that skeletal muscle relaxers are actually a little bit higher here, followed by duloxetine. And then third line, once again, is opioid therapy. So let's talk a little bit about like just an overview of what I want you guys to get out of this. So first, for both of these therapies, we do want to start out with non-opioid and non-pharmacological therapy when possible. So that is consistent across both acute and chronic pain. Once again, you do want to try to treat the patient's underlying conditions. If you cannot find conditions, that's another story for another day. If a patient has severe pain, trauma, surgery, or given PRN opioids at the beginning can be appropriate. You always want to maximize non-pharmacological therapy, and then if you do prescribe opioids, try to start out with 3 to 5 days. As far as opioids for chronic pain, do remember these at greater than 50 millimeter morphine milliequivalents per day, and this greater than 90 morphine milliequivalents per day. If you're not seeing benefit, consider tapering.